So Stephen, ladies and gentlemen, it's a real pleasure to be here with you this morning or this afternoon now. So I've got a few difficulties in giving this lecture. It's a Friday. I think we've all probably had quite a long week at work. We're in Manchester with Dr. Hobson's favourite football team. It's the end of a working week. And I'm going to be talking about small bowel motility, which puts most people to sleep, but hopefully not today. So, whilst we have a number of techniques to measure small bowel motility, indeed motility throughout the GI tract, I think this is probably an area that's significantly underlooked, but it can actually be very useful. And hopefully by the end of this, I'll convince you that motility testing in the small bowel is actually really worthwhile for a number of selected patients. So over the next half an hour or so, we'll talk about how the motility in the foregut and midgut is controlled from a neurological point of view, and then really try and critically appraise the testing techniques that are available, whether they be catheter-based techniques, scintigraphic techniques, capsule-based techniques, breath testing, and MRI and ultrasound. So the enteric nervous system is arguably as functionally complex and heterogeneous as the central nervous system. And the sort of figures I quote to patients are that more neurons in the gut, in the human gut, than there are in a brain of a cat. Indeed, there are more neurons in your gut than there are in your spinal cord. So this is a very nerve-rich environment. And indeed, the gut can function without any connections to the central nervous system whatsoever. It doesn't function quite as efficiently, but it functions nevertheless. And broadly speaking, the gut has a dual nervous supply, so the submucosal and the mucosal plexi, which really function in terms of enhancing motility, but also around changing secretor motor patterns within the gut. And clearly there are important immunological controls within that. So the gut is a very nerve-rich environment. But in addition to that intrinsic or the enteric nervous system, this is also supplemented by the automatic, or what we term the autonomic nervous system. Now, going back to your basic anatomy and physiology, the autonomic nervous system has two broadly antithetic branches. The purpose of the autonomic nervous system is really to maintain homeostasis. So to really integrate the external environment with the internal milieu. And those two antithetic branches we refer to as the sympathetic and the parasympathetic nervous system. And the main neural substrate of the parasympathetic nervous system is the 10th cranial nerve, the vagus nerve, coming from the Latin to mean wandering nerve, and this nerve wanders throughout the body. It innervates the entirety of the GI tract except the distal third of the colon, and has really important functions within the GI tract. So it's important in terms of regulating motility within the gut. So generally speaking, heightened vagal activity speeds the gut up, but we also know it has important functions in terms of mediating hunger and satiety, and increasing appreciation that it also has an antinociceptive or an analgesic effect in the gut. And this is one of my main research interests at the moment, as to whether we can therapeutically modulate vagus nerve function in the gut by stimulating the vagus nerve through the skin to either improve motility or reduce pain in the gut. And clearly that has a number of potential therapeutic benefits in patient groups. But bringing that all together, you know, we're not just an enteric nervous system or a gut or an autonomic nervous system. Patients, when they come to see us, are a whole package. And we can consider all of these nervous systems in what's termed the brain-gut axis. And this construct really links that entirety or holistic approach to what's going on in the gut. So stress, whether that's infectious stress, psychosocial stress, or even pain, activates a very complex physiological response, mediated in part by the stress-responsive physiological nerve systems, namely the autonomic nervous system and the HPA axis. And these impact on the gut, on the enteric nervous system, but in a bi-directional manner. So the gut can affect the brain, but also the brain affecting the gut. And you think, we've all done exams at one point in time or another, I would imagine, that when people are stressed as they're about to go into an exam, they're often dashing back and forth to the loo. So that really is the brain-gut axis in action. But we know this brain-gut axis can also be considerably modulated by a number of other factors. So personality. So when we often see a patient, we know perhaps just as they come through the door that they're going to be anxious, they're going to be a difficult patient, it's going to be hard work. So again, that's the brain-gut axis in action. Genetics probably also modify this system, and there's an increasing appreciation that the bugs in our gut, what we refer to as the microbiota, also fundamentally change how these interactions occur. So what happens when it all goes wrong? Well, any change at any level of the brain-gut axis can lead to changes in motility, changes in sensation, and this concept that we refer to as visceral hypersensitivity. But why do we need to measure motility? What's the utility of this in the patients that we see? So, accelerated, normal or delayed motility can't always be reliably mapped onto any particular symptom profile. And why is that the case? Well, I would argue that the gut doesn't really have a very big vocabulary. So it can either work too quickly, it can work too slowly, it can get a little bit distended and bloated, it can be painful or have discomfort. But really beyond that, the GI tract doesn't have a big vocabulary to express disquiet and therefore symptoms. We know that in these group of patients that these symptoms are often unexplained. They often go to a number of physicians. They have a number of physiological tests. I'm sure we can all think of patients who've had umpteen pointless endoscopies and colonoscopies over the year for the same symptoms. So these patients, notwithstanding their personal impairment of quality of life, also cost the NHS a lot of money. In addition, what can we do when measuring motility in these patients? Well, first and foremost, we can establish whether there's a treatable diagnosis. And in some patients, actually establishing a diagnosis is the first step to improving their quality of life and reducing their symptoms. But really, the second purpose of motility testing is really to delineate symptoms and allow diagnosis and treatments to be instituted. So what's the ideal test in this arena? Well, I think the test itself has to be as non-invasive as possible. It needs to be widely available, convenient, ideally not expose patients to ionising radiation or a significant dose of ionising radiation where possible. Assess GI function in the postprandial state as well as the resting state, and within the lumen be able to differentiate between food, secretions and air. The ability to use provocative measures to try and reproduce symptoms so that you can measure them and then try and map those onto an abnormality. But we have to remember that the GI tract is one long tube. Sure, it's got a couple of valves in it somewhere or another, and it's bigger in some places than another, but actually it's one long tube, and that's part of the problem, I think, in the motility testing that we have at the moment. We tend to focus on just the stomach, just the esophagus, just the small bowel, where actually this is a one long tube in continuity. So we need to be evaluating both before the segment of interest and after the segment of interest. Choosing the patients for testing, I think this is fraught with difficulty. Choose your patient wisely. I think that's the key thing. If it quacks like a duck and it walks like a duck, or waddles perhaps, then it probably is a duck. So if you have a patient with abdominal pain, bloating and some change in form or frequency of stool, it's likely that patient has irritable bowel syndrome. So looking for other, perhaps more erudite diagnoses is often not helpful in these patients, and indeed it often gives them a degree of anxiety that you as the healthcare provider don't really know what's going on, so we'll do another test. And that creates anxiety for the patients, which often winds their symptoms up. But some symptoms that I think that are suggestive, particularly of delayed gastric emptying, and this is by no means an exhaustive list, so early satiety, that feeling of fullness, or postprandial epigastric discomfort, clearly nausea, vomiting, regurgitation, bloating, distension, abdominal pain, and indeed in some cases where they have significant vomiting, weight loss and electrolyte abnormalities such as hypokalemic alkalosis. Symptoms suggestive of small bowel dysmotility, well again, pain, distension, dilation of some parts of the small bowel on imaging. And then in certain clinical situations, you'd be thinking particularly about those patients with connective tissue disorders such as scleroderma, or indeed more recently recognised Ehlers-Danlos syndrome. So for the next part of the talk, I'm just going to look at and critically appraise some of the testing techniques that we have available to us. So we've got the scintigraphic based measurements. So gastric emptying scintigraphy is considered to be the gold standard for measuring gastric emptying. So how does this test work? What are the principles behind it? Well, you feed a patient a low-fat egg white meal. Within that meal, the egg is inoculated with technetium. Technetium shows up on a nuclear medicine scan, and then you perform scintigraphy at baseline, 1, 2 and 4 hours to assess the emptying of solids. So this is a reasonably physiological meal, although I would say 240 kilocalories for a meal is actually not very much indeed, really, is it? Most patients having breakfast would probably be having 500 or 600 calories. So I think that's one weakness. So the 1 hour scan you do to detect very rapid gastric emptying, so be looking for a percentage retention of less than 30%. The 2 and 4 hour scans are used to detect delayed gastric emptying, and if you have a retention of that technetium of more than 60% or 10% respectively at those time points, that would be considered to be delayed gastric emptying. So these are some of the pictures that one gets from the nuclear medicine department. So you see the meal here at baseline. At 2 hours, some of it's gone into the small bowel, and by 4 hours, it's all in the small bowel. So this would be normal gastric emptying. Vis-a-vis now this trace, where you can see that at 2 hours, there's still quite a lot of that activity in the stomach. And at 4 hours, there's still a significant residual activity. And there's a number of ways of measuring this, either percentage retention or gastric emptying half time. What about small bowel scintigraphy? Well, again, very similar principles in that they map and track that radioactivity through the small bowel. This can be quite a prolonged test for up to 10 to 12 hours, and certainly it's rarely performed outside North America. What are the disadvantages of scintigraphy? Well, as I mentioned, it's not universally available in all institutions. It does involve a degree of ionizing radiation, the different protocols for measuring it, and small test meals don't always reliably induce symptoms. There's been some really nice work from Mark Fox and colleagues when he was in Nottingham, developing this idea of a Nottingham test meal, which has both a nutrient, a solid and a liquid component, and filling and dyspeptic sensations are also measured during that test. And that may go some way to improving the provocation aspect of this test. What about catheter-based technologies? Well, we've heard this morning very eloquently from Rami around esophageal manometry, but also similar technologies exist for Tro Duodenal Manometry. Again, a high-resolution catheter is then placed down the esophagus through the stomach into the small bowel, and you can measure motility in a similar manner. This is generally used for patients with suspected small bowel pseudo-obstruction, particularly if they have a muscular cause, what we refer to as a myopathy, or a neurological cause, a neuropathy. And based on the traces, you can, to a degree, differentiate between the two. And these are often used in the context of other GI motility tests as well, to exclude a panenteric phenomenon. So anteroduodenal manometry essentially measures the presence of migrating motor complexes and their three phases. It's recorded by pressure sensors in a similar manner to an esophageal high-res catheter. But the position of the tube relative to where the pylorus is crucial, and often it's very difficult to position these tubes because they're often done by hand with a balloon on the end of the tube that then drags it down into the small bowel. So it can take some time to place this tube. Often you need fluoroscopy as well to make sure the tube is in the right place. Now, I don't know whether anybody's had small bowel motility done. I have for a research study. It took 4 hours to place the tube, and you were feeding it in sort of 5 centimetres every 15 minutes, and it's jolly uncomfortable, and I would argue doesn't really measure the standard physiological state. So these are the kind of traces that you get from these tests. So we have from proximal to distal, so you've got antrum and then duodenum, and you can see the different phases of contractions on these tests. And then you give the subjects a standardised test meal and look how those migrating motor complexes change in the postprandial period. This is an example of very disordered motility within the antrum and the duodenum, and this is in a patient with chronic intestinal pseudoobstruction. What are the disadvantages? Well, again, it's very difficult to get these tests. There are only 2 or 3 centres in the UK that regularly perform these. Interpreting these traces need a high degree of expertise, and probably in the UK we have probably 5 people who can report these tests. And as I mentioned, the catheter placement is very challenging, as is the length of the study as well. What about capsule-based technologies? Well, I think this is quite an interesting development. So we now have the wireless motility capsule, referred to as a smart pill. This is a very similar size to standard wireless video capsule endoscopy, which many units have, and essentially adopts a similar principle, except with the wireless motility capsule it measures pressure, temperature and pH as it traverses the GI tract, in contrast to the capsule endoscopy, which takes video essentially as it tumbles through. So this is a relatively non-invasive technology, no radiation. It can monitor patients for up to 5 days. That's the length of the battery life in the capsule. But it can measure both compartmental physiology measures, both in the stomach, small bowel, and the colon, but also gives you an idea of whole gut transit as well as strength of contractility. Sorry, this doesn't project very well, but again, essentially there's a standardized testing protocol. So the patient comes into the unit in the morning, they have fasted overnight, they're given a standardized meal with some water, they ingest the capsule with 50 ml of water, and then they're allowed to go home and resume their normal daily activities. So actually quite a physiological test done in the patient's own environment, doesn't need a catheter, and generally speaking the results can be very useful indeed. These are the kind of traces that one gets from a wireless motility capsule study. So here in red you can see the contractions, so this measures pressure. The green line is pH, so as the patient ingests the capsule there's a rapid drop in pH as that capsule enters the acidic environment of the stomach. As it transits across the pylorus, there's then a sudden rise as it enters the duodenum, with a gradual rise across the small bowel. Across the ileocecal junction, there's a drop in pH then as it enters the colon, and then you can confirm that the capsule's been excreted by a sudden pressure temperature drop down to the temperature of the toilet water. We've occasionally seen the odd trace where this has been repeated. This is where the patient has fished the capsule out and re-swallowed it, but not one I would advise you to do, particularly before lunchtime. So looking at the traces in a little bit more detail. So as I said, there's a drop as it enters the acidic environment of the stomach, and also a drop across the ileocecal valve. And you'd say, well, why is there a drop across the ileocecal valve. You know, this is not stomach, it's not an acidic environment, but actually this probably represents heightened fermentation in the cecum. Remember, fermentation, the byproducts of that are short-chain fatty acids, so that's probably why the drop there occurs due to heightened cecal fermentation. So in the ileum there's a low bacterial load and therefore a relatively high pH. Lots of bacteria in the cecum, short-chain fatty acids, and that probably explains the drop as one transits into the cecum. This technology has large amounts of standardized normal reference values now in relatively large numbers of healthy individuals. Again, would you say 215 healthy individuals is a reasonable sample size to define your normal values for a physiology test? Probably not, but in comparison to a number of tests that we use on a routine basis, actually these numbers aren't bad at all. What about standard video capsule endoscopy? Well, I think this is quite a nice, interesting technique pioneered by the group in Barcelona, and this essentially uses computer vision analysis of those endoluminal pictures really to define and look at small bowel contractions such as luminal closures and propulsive contractions. But the problem is with this technology is that it has become commercially unviable and is now not being taken forward. Magnetic capsule, I think this is another interesting technique. So this involves the patients wearing a sensor both on the front and the back of the abdomen. Again, they swallow a capsule and you can track the movement of that capsule both in the aboral direction but also retrogradely as well as it moves round the bowel. So I think this technique is still at the research phase, but I think one that has the potential to enter clinical practice with time. What are the disadvantages of the capsules? They're expensive. What's the wireless motility test cost? Capsule? Anyone? £100 was it? 400, probably nearer to 1,000. So this is not necessarily going to be that viable in the NHS. Capsules can fail or be retained. There are a number of case reports of smart pills being retained in patients with hitherto unidentified small bowel cancers. They're large, non-digestible objects, so these don't actually really replicate what happens after a meal. It's not widely available in the UK, and as I said, the video capsule is not being developed anymore, and the 3D transit's still a research tool by and large. What about breath testing based measurement of motility? Well, this is the 13C octanoic acid gastric emptying test. So octanoic acid is rapidly absorbed after it's expelled from the stomach, transported to the liver, and it's metabolized within the liver to heavy carbon dioxide, which you can then detect in the breath. So alterations in C13 to C12, C12 is the normal isotope, really reflects gastric emptying, and this again can be performed with a standardized meal. These are the sort of curves that one gets. So this is the normal emptying curve in yellow, as you can see here. This is more rapid gastric emptying, and the emptying here is much more consistent with delayed gastric emptying or gastroparesis. What about the standard lactulose hydrogen breath test? Well, as we've heard earlier, this is a simple non-invasive test. The orocecal transit time was fashionable to be measured with this test for quite some period of time, but I think there are major pitfalls using this test as a transit study. So what if the patient has concomitant bacterial overgrowth, which is pretty common in these kind of patients? And lactulose itself, remember, it's a laxative. It can itself accelerate small bowel transit, so you may not get a true reflection of transit time by itself. And it also causes bloating and distension in a lot of patients. I don't know whether any of you have tried lactulose, really sweet, sticky stuff, isn't it? And actually it causes bloating and distension, certainly in me and in a lot of patients as well. So we'll skip that one, but just to say that what breath testing in terms of lactulose is useful for diagnosing carbohydrate malabsorption, but not in measuring orocecal transit. Again, some of the difficulties, whilst octanoic acid testing for gastric emptying is quite a useful test, no ionising radiation, its availability is limited in the UK. And as we've discussed, there are lots of confounding factors with lactulose. I think one of the new kids on the block, championed by Alex Menis from UCLH and the Nottingham group, is really around MRI and ultrasound-based methods of assessing emptying. So using T2 weighted MRI cine images, you can begin to map motility, both in the small bowel, again non-invasively, and then you can even examine areas of interest within a particular segment of bowel. The beauty of this study is that you're measuring both before and after the region of interest, so you're getting a much better picture of more global motility as well, and you can measure luminal diameter, contraction ratio, contraction cycle, and I think this is a really interesting technique. Similarly, ultrasound is increasingly used, particularly in children, to look at gastric emptying in response to a meal. A number of parameters one can measure, including contraction frequency, cross-sectional area and amplitude, and you can derive a motility index from frequency and strength of contractions. The disadvantage of some of these techniques, again, they're largely limited to the research setting, but I think certainly with MRI, this doesn't require a different scanner. The protocols are slightly different, and I think may well become in the next 10 years a way to screen motility. It's never going to be as accurate as good old-fashioned catheter-based technologies, but I think it will allow us to screen whether a patient has abnormal motility, or indeed dysmotility. So, ladies and gentlemen, I appreciate that's a whistle-stop tour of gastric and small bowel motility. It's just to say there are techniques out there to investigate your patients. Choose your patients wisely. Don't over-investigate patients. I think you need to ask the question, what are you looking for? How is this test going to change your management of a patient? And clearly you need to exclude inflammatory or malignant disease beforehand. Each test has its own strength and weakness, and again, you need to be tailoring the test that you're choosing to the specific patient. But certainly in my experience, these results can really help you with your diagnosis and to institute treatment. Thank you very much.